suggestion is next year, let's try to make Carcinoid Awareness Month, May or June.
Yeah,
The weather would be a little bit better.
I'm with you on that.
Before I start, I'd just like to say a couple of words. This year, we lost somebody pretty special. Monica Warner was a dear friend to both the physicians and the patients of our community. She was a driving force in the development of this and many other carcinoid support groups. She was always active in our meetings, and we will certainly miss her presence and her camera. To Richard, we offer our sincere condolences and our assurance that Monica will always be remembered here. Richard. A little bit about myself before we get started. I have been in the solo private practice of medical oncology for over 25 years. This not only makes me kind of a dinosaur, but an old dinosaur by today's standards in the medical community. I've devoted my practice to giving patients care in a small private setting. Although over the years I've had the opportunity to participate in many clinical research trials as an investigator, I essentially practice in the trenches of the war on cancer. We call it in the front line. So I have to rely on the research of others, like Dr. Waltering and like Dr. Warner, who are here today, to give me the best weapons available for this fight. We're going to start at the beginning, and I'm going to give you a brief summary of carcinoid and neuroendocrine tumors. Neuroendocrine tumors are endocrinologically active tumors that are not localized in any one organ, such as the pituitary or thyroid tumor, but rather share a common embryonic origin of the neural crest and the neuroectoderm. These tumors include the gastroenteropancreatic tumors such as carcinoids, insulinomas, gastrinomas, somatostatinomas, glucagonomas, and VIPomas. Some of these tumors are non-secretory and can be classified as extrapulmonary and small cell carcinomas. Carcinoid tumors are the most common of the neuroendocrine tumors, with most carcinoids arising from the rectum, appendix, or small intestine. Most neuroendocrine tumors are malignant, but are slow growing. The clinical presentation depends on the hormones secreted and the sites of the disease. Of course, like any malignancy, there is always the potential for metastases. Laboratory tests used in the diagnosis and management of neuroendocrine tumors include urinary 5-HIAA, chromogranin A, gastrin, VIP, serotonin, insulin, glucagon, pancreatic polypeptide, neuron-specific enolase, metanephrines, and a whole host of other agents. CAT scans, MRIs, Arctria scans, and MIBG scans may be useful. Conventional PET scans usually are not helpful in the diagnosis. In my opinion, recent work with the F-DOPA PET scan has not been that compelling. It is really up to the physician and the patient in reviewing their presenting symptoms, the workup, including laboratory and radiologic scans, to come up with the appropriate diagnosis. As with most solid tumors with localized disease, surgical resection is the initial treatment of choice. Systemic therapy with the somatostatin analog, octreotide, can reduce symptoms as well as control the tumor itself, and may be used prior to surgery as well. In advanced cases, systemic therapy using chemotherapy and newer biological therapies, in addition to octreotide, can be used. Localized therapy can also be revisited in the form of hepatic resection or chemoembolization for selected cases of advanced disease. Some of the presentations from the 2009 Neuroendocrine Tumor Symposium held last month in North Carolina particularly interested me. There were some new developments that are worth mentioning. Some new agents were presented, such as an RAF1 activator, leflunomide, which is commercially available as Arava, which is already on the market for the treatment of rheumatoid arthritis, has demonstrated significant activity in the treatment of rheumatoid arthritis. An mTOR inhibitor, everolimus, also available as Afinitor, already on the market for treatment of advanced renal cancer, has also demonstrated significant activity in the treatment of advanced carcinoid tumors. These agents will certainly come into play more and more in the upcoming months. Another presentation that was of interest was that we know that neuroendocrine tumors express VEGF receptors, that's vascular endothelial growth factor receptors. Targeted therapies available now, such as bevacizumab, sorafenib, and sunitinib, have been shown to have varying degrees of success as treatment modalities. At this conference, another agent, venetoclax, also demonstrated significant activity and certainly warrants further study. Another presentation that I thought was very interesting, I'm sure Dr. Grebin will comment on, is that an increase in endothelial growth factors was demonstrated in patients after chemoembolization was accomplished. This increase in endothelial growth factors in the patient may adversely affect the long-term success of the procedure because the increase of this substance may stimulate further growth of the tumor. Targeted biologic therapies, which I just mentioned, may have a prominent role here and can be used after chemoembolization in order to blunt that effect. Also, a novel somatostatin analog, pasiriotide, has been recently formulated as a long-acting substance and has also shown activity in sandostatin resistance. Newer assays were presented, many unfortunately not yet clinically available for widespread use, may help predicting outcomes in patients. Also presented, unfortunately, was the fact that some of the older assays that we're now using may not be as helpful as previously thought. I hope to hear about some of these developments and more from today's prominent speakers. Today we are pleased to welcome back Dr. Eugene Waltering and Dr. Richard Warner, and also to welcome first-time speakers, Dr. Craig Grebin and Jerome Zaks. Our program also includes some extremely important supportive issues. Speaking of supportive issues, there is, of course, the subject of healthcare reform that seems to find its way into every discussion. So as long as I have this captive audience of patients, family, caregivers, and fellow physicians, I'm going to have my 2 cents on this subject today. I want to start out saying that if you are against healthcare reform in this country, you are wrong. There is definitely room for improvement. The system needs help. It needs an adjustment, an elimination of waste, including but not limited to administrative and malpractice costs. We need to make our insurance companies competitive and accountable for every dollar of our premiums that they collect. And we also need tort reform. But if you are considering the massive healthcare reform initiative that our federal government is currently trying to force upon us, be careful what you wish for. We already have the finest healthcare in the world. Remember that the leaders of foreign countries come here for their healthcare. You have never heard of an American leader going abroad for any sort of treatment. And yet, the bureaucracy wants to fashion our healthcare after a European model. Recent data shows that a comparison of patients, and I'm going to talk about cancer because obviously that's what I know. Recent data showed that a comparison of patients with 6 comparable tumor types and stage at diagnosis, the 5-year survival of an American patient is uniformly greater than that of a European. A study published by the University of Pennsylvania Population Study Center in July of this year and was funded by the government's own Social Security Administration concluded that we do not have a poorly functioning healthcare system with respect to longevity outcomes. Do we need to improve the distribution of healthcare? Certainly, yes, but not at the expense of diluting the care that makes this system so great. You cannot cut the same pie of healthcare dollars into more slices and have each slice remain the same size. It simply doesn't work that way. The slices would necessarily shrink, and the method has to be this dirty word, rationing. Rationing is the mainstay of the British healthcare system. Rationing comes in various forms, so beware. It can be hidden in terms such as using preferred drugs or suggested treatment guidelines, which can be made to be neither preferred nor suggested, but rather mandatory and compulsory. This must be included by necessity in any completely and totally government-run healthcare plan. This is not the way we as physicians were trained to treat our patients, nor is it the way our patients deserve to be treated. Fix the insurance industry, fix the malpractice issues, stop wasting healthcare dollars in an ever-increasing bureaucracy, but for Pete's sake, don't ever allow rationing. So enough of that, my rant and my rave, and I'm going to turn it over back to Robert. Thank you.